All right, let's get started. Do you guys have any more exams this week? No? Good. Okay. So you're all refreshed. You're ready to look at this. Okay, good. So I posted a bunch of stuff for you. And what I posted was, first of all, some guide, and I emailed. I hope people paid attention because I emailed a few slides for everybody to review as a guide to sort of refreshing your memory on normal stuff, right? That's pertinent to this material. So I certainly hope you all know that because we don't have time to go over normal in sufficient detail. And you've already had this stuff before. You should be able to handle this without me nagging, all right?
Okay, Dr. Bravo, just like every other class here, we're going blind. We'll work through it somehow. We'll get through it.
You're telling me that you didn't go over the material I posted.
I don't want to lie to you. Friday, it was good. I didn't go through it at all.
All right, doctor. I will make a note of that. Okay, two other things that are going to come very handy. I put them together as a sort of a way to help students have the global picture in mind and have everything in one place. I put together two charts some years ago, a couple of years ago. One is the anemia chart, which has pretty much all the bits and pieces, you know, in one place in terms of different types of anemias, where the defect is, and what the consequences are. It's all very, very clear. At least that's what in the past students have been saying. It's very helpful as a template to when you're studying this stuff. Second, I also posted white blood cell disorders chart, designed exactly the same way, again, to help with just kind of last-minute review and to see where things fit in the grand scheme of things. Today, we're going to look at red blood cell disorders and as much of the bleeding disorders as we have time for. And in the context of today's material, I also posted a case that was published in New England Journal of Medicine on sickle cell disease in a patient who presented with sickle cell crisis. I think, well, I don't expect everybody to know this and be able to understand all of it. I think it's a really good, well-described, well-documented case that shows the bits and pieces of how these patients present, what kinds of problems they might have, and the detailed discussion that goes with, you know, a lot of the people who discuss the case in this publication are extremely knowledgeable, and I think it's an excellent insight into how this works. So I strongly recommend just reading that case and, you know, trying to understand the gist of it. What are the major problems with sickle cell anemia crisis? All right. And then, of course, you'll have the separate PDFs for red blood cells, bleeding disorders, and white blood cell disorders. And again, today we're doing red cells and bleeding. So, of course, the objectives are consistent. You need to know the terminology. You need to be able to describe pathologic processes and also describe mechanisms and clinical features of common anemias. All right, so when it comes to red cell disorders, this is the outline of what we're going to be talking about. The vast majority of problems that we generally have to deal with when it comes to red cell disorders are deficiencies, so-called anemias. Neoplasia is much less common, and no matter which aspect of the disorder we're talking about, always need to know terminology. We will talk about classification, and I'll explain why that's helpful. We'll talk about nomenclature, pathology, signs, and symptoms, okay? So pretty much the same kind of thing we do every time with every lecture. So I don't need to belabor this. Most of you even probably are aware that red blood cell disorders are extremely common, and they do manifest in the head and neck area in more than one way. So I'll show you a few examples. And then the problem is that because these are disorders that affect a lot of cells and tissues throughout the host, that means that the host tissues are different in the way that they handle insult. So they can be more susceptible to infections. You can have epithelial atrophy, which of course predisposes it to ulceration. There is an effect on liver function, on spleen function, and then there are all sorts of implications and associations with bleeding problems. So it's very important to understand the basic principles of anemia, types of anemia, and how they interact with the head and neck area tissues as well as other cells in the hematopoietic system. This does affect dental management, and it can affect both use of certain dental procedures, and it can also affect prescription writing. So it's very important to know the gist of it. I posted this. This was part of your document, the PDF that I gave on hematopoietic disorders, but this is the normal scheme, and I'm just going to very quickly remind you that when we talk of red blood cells, we're only talking about one subset of the vast number of blood cells. So everything starts as a pluripotent stem cell, which then subdivides into two lineages. One is the myeloid lineage, the other is the lymphoid lineage. And once this division has taken place, these committed precursors will only give rise to their group of cells. And red blood cells come from the same lineage as other myeloid cells, including neutrophils, eosinophils, basophils, monocytes, and mast cells, as well as platelets. They all come from the myeloid lineage. Okay? When it comes to lymphoid lineage, we're going to talk about that when we talk about white blood cell disorders on Wednesday. But remember that red blood cells and platelets are part of the myeloid lineage. When it comes to the importance of red blood cells to the host, red blood cells with their contents are crucial to providing oxygen to the host, right? Everybody knows that. And it's the oxygen carrying capacity that we focus on when we talk about deficiencies in red blood cells. Why? So red blood cells are specialized because they have hemoglobin, which is, of course, you remember, hemoglobin A, and both its quantity and quality can affect its function. So oxygen carrying capacity of red blood cells is affected by how much hemoglobin they have and how good structurally the hemoglobin is. It's not intuitively obvious that nuclei are important for red blood cells because red blood cells don't have nuclei. Well, it turns out that DNA synthesis in the nucleus in the developing erythrocyte is also extremely important in what happens to the red cells. Because every step before the mature red blood cell enters the bloodstream, all of those preceding steps of development along the myeloid lineage involve cell division, differentiation, which involves a nucleus. Okay? So synthesis of DNA in the process of those steps is crucial to making the right kind of red cell. And you will see how disturbances in DNA synthesis can lead to deficiencies in red blood cells called megaloblastic anemia. We'll talk about that. And finally, of course, it's the vessels that bring the red cells to all the tissues. Therefore, if there are problems with the vessels, you can develop problems leading to anemia. So we're talking about leaks and obstructions as things that have consequences for red cells and oxygen carrying capacity. Okay? Whether it's going to be localized because there's a clot somewhere, or there's widespread leakage, which means the the entire host tissues are affected, that, of course, is the difference in outcome. Everybody remember what this structure is? Spleen, thank you, yes. And it's very important to remember that it's a major part of the circulation system, and a big, very important role that the spleen plays. It has this red pulp, which is where the red cells that have aged out, are senescent red cells, about 120 days old, or damaged red cells, abnormal red cells. That's where they go to die. And so the function of the spleen is very critical in maintaining normal red cell populations, and also contributes significantly to certain kinds of disorders of both red cells and platelets and some other cell types. So spleen is an important component. Right, so when we talk of anemias, we're talking about decreased oxygen carrying capacity of the peripheral blood. So this is a systemic problem. It's a global problem. And to measure the patient's ability to provide normal oxygen to the tissues, there are a number of parameters, and you need to know them. You need to know that red blood cell counts, normally between 3.5 and 6 million. Actually microliter, and I'm sorry, this should be a microliter, not milliliter. I should correct that. Is the normal value, and so a decrease below 3.5 million, and it does depend somewhat on whether it's a male or a female, will constitute decreased oxygen carrying capacity of the blood. And of course, the more reduction, the more severe the anemia. An important value that's used regularly, I see this on current lab reports all the time, is the reticulocyte count. A reticulocyte is the last step before a mature red blood cell actually forms. So this is the mature normal red blood cell, biconcave cell with a pale center, somewhat orange in color. And the reticulocyte is the less mature form, which still has remnants of nucleic acid in it, and it's a larger cell. And this cell tells the clinician, the numbers of these cells actually tell the clinician how well the bone marrow is keeping up with the demand. So normally, we expect about 0.5 to 1.5% of reticulocytes per microliter, among the red blood cell count. We expect that to be somewhere in this range, 0.5 to 1.5%, but what happens with, let's say, acute blood loss in a normal individual, there will be stimuli to kick in additional red cell formation, and this percentage is going to go up. If this percentage goes down and the patient doesn't have enough red cells for whatever reason, it tends to tell the clinician that the bone marrow is not functioning properly. It's deficient in some way. So this is a number that's included on lab tests to indicate how well the bone marrow is working. Of course, hemoglobin is, everybody knows that hemoglobin is one of the major parameters on a blood test, and these are the normal values between 12 and 18, and you have to remember that the higher values are more characteristic of males, and somewhat lower values are more characteristic of females. And so the cutoff for actually determining if a patient has anemia or not is going to be slightly different if it's a male or a female. But this is the total range for males and females. And then there's the hematocrit, which is packed red cell volume in percentage, packed red blood cells to the total volume ratio. So it comes between 37 and 54%. Again, similar to hemoglobin, the lower values are more consistent with female normal values, and the higher values are more consistent with males. They measure the mean cell volume, how large the cell is, which you'll see as we talk about anemias, why that matters. And then the cells can vary in size. Normally you have a little bit of variation in red cell volume. And the normal coefficient is this, 11.5 to 14.5. But in cases where a patient develops, especially with certain kinds of anemia, the variation in cell size increases a lot, and so that coefficient is also going to increase. So typically the coefficient won't go down, it will go up if there is an abnormality because there is increased variation in cell size, because something is happening in the bone marrow that's preventing from normal regulation of red blood cell production. Okay? So all of these are numeric values, of course, and the one other parameter that can't be evaluated automatically but has to be done by using blood smears is to look at cell morphology, and it often contributes a very important set of parameters that help with making the more accurate diagnosis on the type of anemia a patient has. Okay? So this is what that chart I was telling you about, the anemia chart, looks like. Those of you who haven't looked at it yet, please do. It's going to help a lot in preparation for red cell disorders. And it's divided into groups based on what's called a mechanistic classification, and I'll explain the classification in a bit. But it's important to realize that all anemias can be basically subdivided into one of three groups. Either the anemia is due to blood loss and or iron deficiency, or there's decreased production because of some other reasons, and we'll talk about those, or there is increased destruction of the red cells. And again, we'll talk about specifics of those. And obviously, we're not going to cover each and every anemia. We're just going to talk about major examples from these individual groups, okay? So the chart shows you underlying problem for each of these groups, okay? It shows you examples of conditions that you should be aware of that belong to each of these groups. So you have 3 in the category of blood loss, iron deficiency. I have 6 here listed for you in the group of decreased production, and 8 of them listed in the group of increased destruction. But we're mainly going to focus on how do these anemias develop, what's the underlying problem, and then look at a few examples of major types of anemia. And finally, of course, in this chart you have common key features of these anemias. So those that tend to be associated with blood loss or iron deficiency, features that are associated with decreased production, and features that are associated with increased destruction. So again, we'll be looking at that in just a minute. All right, so there are 3 different classifications that are in common use. The one that WHO proposes has to do with just the level of hemoglobin. And the breakdown is by age, sex, pregnancy status, and in general, you know, for example, children between 6 months and 5 years, if their hemoglobin drops below 11 grams per deciliter, that's supposed to be indicating anemia. Pregnant females, same kind of number applies. But if the female is not pregnant, a drop below 12 is considered abnormal, and so on. And of course, as I already mentioned to you, adult males, their cutoff is a little bit higher because they generally run higher hemoglobin levels. No matter who the patient is, a child, adult, male, female, if the hemoglobin drops below 7, it's characteristic of severe anemia. Any patient. 7 or below, severe anemia, okay? So that's a useful number to keep in mind. Now, the other classification, which is mainly the one we're going to be using, and that's how the chart is organized, is using the mechanistic classification. And because this classification kind of is much more easy to follow. It's easier to follow. It makes a lot more sense because it's broken down by what caused the anemia in the first place as a group rather than as an individual cause. So if you lose blood, you have one type of anemia. If there's decreased production for any number of reasons, and we'll go through the important ones, it's that decreased production type anemia, and finally, increased destruction, also called hemolytic, okay? So hemolysis and increased destruction go together. It's the same thing, means the same thing. And finally, often described in these, when a physician reports anemia in a patient, they'll often use this classification in conjunction with the mechanistic classification. So they will use terms that describe morphology of the cells, which is something you can see on a smear. So cell size, obviously normal size, that would be normocytic, meaning that the patient is anemic, but the cells are normal in size, suggesting that they might just not be making enough red cells. Microcytic means the cells are smaller than normal. Macrocytic, cells are larger than normal. So you can have anemias in each one of these categories. And again, we'll look at some examples and you'll see why that is. It, of course, matters because hemoglobin is the main molecule that's required in order to bind oxygen. And you remember heme with iron as the main part of the hemoglobin molecule where the oxygen actually binds. Then the degree of cell hemoglobination, how much hemoglobin per cell you have, is another important parameter, and you can also evaluate that just by looking under the microscope. And pale cells are considered hypochromic. Normal in color, they're going to be normochromic. And finally, they can actually, at least in macrocytic anemias, it's not unusual sometimes to find hyperchromic cells. But for the most part, normochromic and hypochromic, less color, are the characteristics we most often find in anemias. And another thing that helps a lot is the cell shape. And of course, the most obvious example would be sickle cell anemia, because in sickle cell anemia, you find cells that are highly unusual for any other type of anemia. They are shaped like a sickle. That's why, of course, the condition is called after them, named after them. There are two other words to remember. Anusocytosis, that's the term used when the cells vary in size tremendously. So remember the red cell distribution width, that parameter that you can find on a typical report, blood report, would be higher than normal because the cells vary in size too much, excessively. And that's, the term is anusocytosis. And poikilocytosis will indicate that the cells vary in shape a lot. So they're not all nice and round biconcave cells, but some are oval and long, and some bizarre shapes as well. Okay, so those are terms that are important to know. This I just included as a way for you to think about how cell size, cell number, hematocrit, and hemoglobin can be represented by the size and the number of cells. Okay, so you can see here that you can have normal cell numbers, size. So this is your control group, right? These are the normal cells. And relative to that, you can still have normal size of cells like the ones in this group. But if they're reduced in number, then everything, all the other parameters are going to go down as well, because you'll have also lower hematocrit and lower hemoglobin because you have fewer cells to begin with, even though they might be normal-looking cells, and so on. So this is kind of a chart that might help you kind of visualize the scheme, how these different parameters fit together to produce the result. So let me just show you a few examples of variation in size. So anusocytosis, variation in size. So here's a smear from a patient with iron deficiency anemia, and you can see that the cell right here in the middle is actually a normal cell. When a patient is anemic, doesn't mean that all the cells are going to be abnormal. It's going to matter how severe the anemia is. So in this case, actually, this is a pretty severe anemia because very few of the cells are normal. And here's this one example. And what you should notice is that the middle portion, the pale portion of the cell, is usually about 1/3 of the diameter of the cell. And the rest of it should be intensely colored, orange to red. Okay, and you can see clearly that there is variation. First of all, these are hypochromic, okay? These cells have a lot less hemoglobin in them. And there is anusocytosis, variation in size. You can see this is a small cell, this is a larger cell, a large cell here. And if we were to look at the red cell distribution, we'd see that the coefficient actually is high. And finally, we also see evidence of poikilocytosis, so that you see some cells look, instead of being, even if this is on its side, it should look biconcave, which it doesn't. So it's not the normal shape. And in a more extreme example, you see variation in shape. Poikilocytosis is in the case of sickle cell anemia, and you can see the sickling here, okay? And this is a bizarre shaped cell as well. Abnormal shape here. Okay, so there are other different shape types. We're not going to obviously talk about all of them, but just so you can see examples of what anusocytosis and poikilocytosis means. All right, and of course, we can't forget that anemia means problems for a lot of different tissues. Of course, tissues that turn over faster are going to suffer more. So epithelial surfaces suffer a lot. Bone marrow suffers. Brain suffers to some extent. So reduced oxygen carrying capacity of the blood will have a more severe effect on some tissues than others. But overall, the consequences to the host, of course, depend on how severe the anemia is, how quickly it started, and what the underlying mechanism is. Okay, because some mechanisms affect just the red cells, other mechanisms affect all cell types produced in the bone marrow, and so on. Okay, so we'll talk about this in a little more detail as we talk about specific anemias. So, because carrying oxygen to the tissues is very important, and of course our heart and our kidneys are supposed to sort of help us maintain normal blood levels. Certain reductions, particularly severe reductions in oxygen carrying capacity, are going to have an impact on the function of these other organs. So for example, to compensate for reduced oxygen carrying capacity of the blood, one thing that can be done is to increase plasma volume. So there's going to be more fluid retained in the vasculature. There is going to be an increase in cardiac output. So the heart might pump faster, okay? So you might hear an increased pulse rate, right? And the patient might start breathing more rapidly, especially in severe cases, because there is a increased demand for oxygen, and the cells are just not doing their job. So increased in respiratory rate, cardiac output, and plasma volume are intended to try and compensate for the severe reduction in oxygen carrying capacity. So throughout the material, I actually put in a few questions here and there for you to just kind of, as you study this, think about how you would answer those questions and help you kind of guide your study, okay? So what are some more specific major consequences of anemia? Well, first of all, non-specific in clinical terms. So when it comes to nonspecific, meaning these apply to any kind of anemia, whether it's iron deficiency or it's due to a vitamin deficiency that reduces differentiation of cells, or it's because the stem cell is damaged. It doesn't matter. The important thing is global effect on perfusion of tissues, right? So the tissues are going to look pale because there's less hemoglobin coming in. The person will experience fatigue and experience weakness. So when I say non-specific, I mean all anemias, as long as they're severe enough, will present with these features. So obviously, the anemias we will talk about more specifically, you should be able to say that yes, all of these anemias are going to come with these features. But then there are other features that preferentially come with some anemias, but not others. So you'll have to pay attention when you study which anemias are going to lead to increase in bilirubin in the blood, to jaundice, to pigment gallstones. And just as a general principle, you should be aware that if the cells are being lysed, so it's a hemolytic or increased destruction anemia, that's when you get hemoglobin spilling out into the bloodstream, into surrounding tissues, accumulating in tissues, and producing these features: hyperbilirubinemia, jaundice, and pigment gallstones. So think of hemolytic anemia when you see these features. There is a particular feature that comes with one specific anemia. So we'll be talking about thalassemia, but we won't go into a lot of detail. But just so you remember that thalassemia can actually come with iron overload, because patients with thalassemia can be overcompensating for some reason and absorbing more iron than normal. And so in these patients, there are certain procedures that they're supposed to be quite careful, because iron overload is very toxic to the host. And that's very, very specific to thalassemia for the most part, okay? And then there are some anemias that people are born with, right? So you know that sickle cell anemia and thalassemia, I'm sure you all have heard of this, are congenital. And it's the congenital anemias that are going to clearly have a prominent effect on growth retardation and skeletal abnormalities. But also malnutrition in the children, which is more likely to occur in, let's say, in Africa, in Asia. Even iron deficiency anemia due to malnutrition can lead to growth retardation, skeletal anomalies. So it matters when the anemia developed. If it's in a child and it's severe, whether it's acquired or it's congenital, growth retardation and skeletal abnormalities can be evident. Okay, so those are the major consequences. There are some specific things that can happen in cells when the anemia is severe and long-standing. So there will be fatty change is the most common and the most well-recognized effect on cells, and it tends to be reversible because you can provide, the cells that underwent fatty change can actually recover once they get additional oxygen supplied to them. This type of change actually occurs primarily in liver and myocardium as well as the kidneys, and it's because the cells that comprise the main bulk of the organ in these organs are involved in lipid metabolism. So fatty change and anemia, long-standing anemia, go hand in hand, okay? All right, now, when it comes to specifically clinical features, we talked about weakness, fatigue, dyspnea, and mild exertion, lightheadedness, we haven't mentioned yet, but yes, lightheadedness and headaches. Pallor and jaundice, rapid pulse, and skin atrophy with brittle and concave fingernails tend to be the more common types of features, provided the anemia is severe enough. Mild anemias generally don't produce much in the way of common features. So when you think about it, when it comes to weakness, fatigue, where is the main impact? Which organs are suffering? Well, it's going to be the nervous system, it's going to be the muscles. Dyspnea and mild exertion, that's the respiratory system. Lightheadedness, headache, that's the central nervous system. Pallor and jaundice, that's all the tissues that are being perfused that you can examine visually, right? Rapid pulse, that's the effect on the heart. Atrophy of the skin, brittle concave fingernails, all of that obviously is manifestation of poor oxygen delivery to the skin. So always connect those two so that you're fully aware of where the oxygen carrying capacity is having its effect, the reduction of it, okay? Any questions so far? None, okay. So, just to give you a quick general overview, again, we're going to be talking in terms of different types, 3 different groups of anemia using that mechanistic classification. And this is what you need to be aware of. When it comes to an iron deficiency anemia, and right now we're just going to talk about these 2 groups, chronic blood loss and decreased production. Iron deficiency anemia has to do with inadequate iron, and it produces cells that are smaller than normal and paler than normal, so hypochromic and microcytic. So it's not unusual for a physician, for example, if you call a physician and say, what kind of anemia does this patient have? The physician might say it's a microcytic hypochromic anemia. And that should immediately sort of give you an idea that it probably has to do with insufficient iron, whether because the patient is losing iron or because they're not getting enough iron in the diet or both, okay? So when you think about this type of anemia, think about why are the cells small and pale? So you think about the underlying problem, and the underlying problem is the iron that's necessary to make a complete hemoglobin molecule that's fully capable of maintaining its function as oxygen-binding molecule. There's not enough of it being made. So in the bone marrow, yes, the protein is there, the protein is being made. The beta chains, the alpha chains that make the hemoglobin molecule are produced, but because there's not enough iron, hemoglobin is incomplete. Less hemoglobin is being made, and that's why these cells are smaller and paler than normal, okay? Now, in the setting of patients that have severe chronic illnesses, a number of different chronic illnesses that are inflammatory in nature can produce anemias where the cells look normal. They look normal in terms of shape and size. They look normal in terms of amount of hemoglobin per cell, but somehow the number of these cells is reduced because of some of these inflammatory cytokines. So chronic, long-standing inflammatory conditions can lead to an anemia that looks under the microscope as normochromic and normocytic. Megaloblastic anemias. Now we're talking about anemias in group 2, anemias that have to do with decreased production. There are a whole slew of these. Yes?
That slide before, when you were talking about anemia of chronic disease,
yes.
why is the patient anemic?
Because there are fewer cells. So it's not making enough cells. The stimuli that are produced by the inflammatory cytokines are interfering with proper maturation of the cells and output, okay? So it's just a general inhibition of cell numbers. Any other questions? Okay, but when it comes to megaloblastic anemias, the reason they got their name is because the cells are large and they are less well differentiated. And most of them have to do with deficiencies in folate and vitamin B12. There are many different ways not to have enough vitamin B12. We'll only look at one example of a megaloblastic anemia that has to do with B12 deficiency, that has to do with an autoimmune disease called pernicious anemia. So, but keep in mind that there's multiple ways that you might not have enough folate or vitamin B12. And doesn't matter what the cause of the deficiency is, you still end up with a megaloblastic anemia. The features of the anemia are going to be the same, even though the underlying specific mechanistic cause is different. So these cells are produced, they're larger than normal, so they're less mature than normal, megaloblasts, and in most cases, because it's an effect on DNA synthesis, B12 and folate are important for DNA synthesis, the cells aren't differentiating or maturing properly, so it's not just the red cells that are going to suffer, other cell populations are going to suffer too. So they generally have what's called pancytopenia, or reduction in all cell types. But the red cells are the most obvious ones. So we'll look at one example of this type of anemia. And finally, another kind of anemia that doesn't immediately come to mind because it's an effect on all cell types is called aplastic anemia. And this has to do with complete failure of the bone marrow all the way back to the pluripotent stem cell, the one that gives rise to the myeloid lineage, the lymphoid lineage. So every single cell population is affected severely, much more so than in megaloblastic anemia. This is a failure to produce all cell types. And the most common causes of this type of problem are toxins, radiation, drugs, and viruses. And we do see cases presenting in the dental office where the diagnosis leads us to find out that the patient actually has aplastic anemia. It's not that unusual for the case to begin in a dental practice and then be followed up and investigated and turn out to be an aplastic anemia. Okay? And some of the prescriptions that we give to our patients also can have that effect, can actually cause aplastic anemia in our patients. Now, this term is something that most people don't remember very well, called myelophthisic anemia. But it's a very common form of anemia because it occurs in patients who have other major illnesses that affect the bone marrow, most commonly metastatic cancer and granulomatous disease. Those two problems can wipe out the bone marrow. So this time, it's loss of space in which the bone marrow can make cells. It's now the space is taken up by a different process, either by cancer or granulomatous inflammation. So this is different from aplastic anemia because you're not just targeting the stem cells. It's not just poisoning the stem cell. The whole bone marrow space is compromised because now the space is taken up by one of these two disease processes. So patients with advanced cancer, with particularly cancers that have a habit of going to the bone marrow, myeloma essentially involves the bone marrow right from the start, leukemias involve the bone marrow, prostate cancer, breast cancer, they all are very prone to metastasize to bone. All of those can lead to this type of anemia called myelophthisic anemia. And then there are some granulomatous diseases which we won't be talking about, but they can also have the same effect. Okay, so these are all anemias that have to do either with less iron or reduction in production of red cells or their components under other conditions, such as chronic inflammatory disease, lack of vitamin B12 or folate, poisoning of the stem cell, or wiping out the bone marrow in general. Okay? Any questions so far? So this is just a general overview of the groups that you should be aware of. Yes? What, the aplastic anemia? Myelophthisic? Well, again, when a lot of these terms were developed, oftentimes the full extent of the problem wasn't well understood. So you'll see that sometimes the terms are actually incongruent with what the disease is about, which is unfortunate. But, you know, once the term is there, people don't like to get rid of it because it's redefining a whole new category, right? So whatever, it doesn't help much, so we're stuck memorizing, right? Same with aplastic anemia. All cell types are affected, but it's still called aplastic anemia, right? So you have to keep track of that and remember that it's not just the red cells that are affected. Everything is, all the cells are affected. Okay. Any questions? Oh, this is the Russian version of Winnie the Pooh. There he is with his honey, trying to save it from the flood. Everybody remember that book? Oh, it's terrific. One of my favorites. Okay, so let's talk about how they develop. So now that we have sort of a general framework of what kinds of anemias, what can cause anemias in general, let's look at more specific things. The most common one, we're starting with the most common one, anemia that has to do with chronic blood loss or iron loss or lack of iron in uptake. So they're all they tend to be very similar with some few differences. So let's think about, okay, if this patient is having chronic blood loss, give me an example under what circumstances a patient might have chronic blood loss. Let's say from just the GI lectures you just had. Can you think of anything? An ulcer, yes. An undiagnosed ulcer that's been bleeding for a long time. Any other condition? Vomiting, right. So under, let's say, varices, right? Esophageal varices, right? With liver cirrhosis, okay? Anything else? Hemorrhoids, yeah, there you go, another one. Anything else? How about polyps of the colon? Anybody remember what kinds of polyps there are in the colon sometimes? Hyperplastic, and then the one that is precancerous? Adenoma, right, okay. Adenomatous polyps, which are benign, but eventually become malignant. All right, so under any of those conditions, what's happening is with repeat injury, there's more and more bleeding, chronic bleeding. What would the stool look like? Black, right. So black stools, especially if it's upper GI. If it's lower GI, hemorrhoids, you're not going to get black stools. It's too close to the exit, right? So the blood doesn't have time to change from red to black, okay? There's no hemosiderin yet, okay? It's still fresh. Okay, so, but either way, you have some evidence in the stool, and so you're losing and losing and losing, and the patient hasn't changed their diet. They're still eating as much whatever meat or vegetables that contain iron in them. And by the way, meat is better than vegetables. Iron that's associated with meats is better absorbed, utilized. And eventually, the stores, we have certain storage. We have storage in the blood, and we have storage in the bone marrow, and eventually that's depleted because you're losing more iron than you're taking in. Okay? So that will lead to insufficient iron, and what kinds of cells are going to be made when you don't have enough iron? Are they going to be bigger than normal or smaller than normal? Smaller than normal. The term is microcytic. Okay, so you have microcytic anemia. What color will they be? Will they be normochromic, hypochromic, or hyperchromic? Hypochromic, right, reduced because there's less hemoglobin per cell. So the cells are going to be paler and smaller than normal, right? Does it make sense? All right. So this has to do strictly with insufficient iron. And because there's insufficient iron, you can't make a full, complete, assemble the complete molecule, hemoglobin A, to make the red cell normal, okay? So this is the consequence. Strictly effect on the hemoglobin and the cell morphology. And overall, can anyone remember the numbers? What's our normal red cell number range? 3.5 to 6, right? Million per microliter. Make sure you correct that in the PDF. So you can have below that, the numbers will fall below that. Anybody remember hemoglobin levels? Between 12 and 18 grams per deciliter. What would be a severe anemia? What would be the number? 7 grams per deciliter. You can get as far down as that with an iron deficiency anemia. It's a really nasty situation. In this country, it doesn't happen very often, but it can happen. So lack of iron can lead to very severe anemia with very low red cell numbers, low hemoglobin, low hematocrit, and the microcytic / hypochromic type of anemia. Okay, so this is how you think it through, okay? This is the way you kind of assemble it so you understand why, under certain conditions, the anemia looks the way it does. What's the underlying problem, okay? All right, I'm just going to remind you a few things because this is important also for us as when we take care of ourselves. So we lose most of our iron just because cells are shedding. Your skin cells are shedding, cells lining the GI tract are shedding, cells lining the airways are shedding. When you think about all the surfaces through which we can lose cells, that's a lot of surfaces, and I'm sure someone already calculated how many square meters that is. I just don't know the number. But we lose a lot of iron every day with those cells. So in order for us to make up the deficiency, the loss, we need to take in at least 1 milligram in our diet because only 10% of that is typically absorbed. So that's what we need. We need about 1 milligram in order to keep up with just the simple loss with shedding. And there are certain things in our gut that regulate this absorption, but I don't expect you to remember all that. The only reason I mention hepcidin here is because that's the molecule that's affected in thalassemia, which tends to affect iron absorption in a positive way. We increase absorption, and it has something to do with the way hepcidin works in thalassemia patients. This is just for your general information. I'm not going to ask questions about this, but it's always good to have a little bit more background when you're trying to understand this problem. So we have iron coming in through the gut, obviously through the diet. Transferrin takes care of it in the blood. Liver stores it. Mononuclear phagocyte system is important all the way around because it takes the iron, particularly the iron that's in the hemoglobin that's released into tissues. So if we have internal bleeds into the tissues, that's where the mononuclear phagocyte system is particularly important. So remember those hemosiderin-laden macrophages in the lungs? Remember that was a question on your pulmonary exam? That's a very good example of what the mononuclear phagocyte system does. It stores a lot of this iron in the form of hemosiderin. But the point is that all of this, while it's trying to stay contained, there's no way to contain all of it. Eventually, some of it is lost through shedding of the cells of the skin and GI tract and endometrium and so on. Okay? All right. Here's that example. If any of you remember, you had very similar looking cells on one of the images in the pulmonary lecture that talked about hemosiderin in the lungs in congestive heart failure. Well, you see these cells in other tissues and organs all the time because every now and then we do get little leaks, blood leaks into the tissues, whether it's because of trauma or because something damaged the wall of the vessel, sometimes inflammation. And so the vessels become leaky, so red cells can exit too. And when they do that, macrophages are right there, ready to pick up the hemoglobin that's being spilled and take it back into the bone marrow and allow it to be recycled, reused again to make new red cells. Okay, so anything that's leaked into the tissues is not going to be lost. It's the bleeding into surfaces where it's taken out of the host. That's when that's what matters for loss of iron in us. Okay, so as I already mentioned, you can either lose iron through blood loss, or you can not have enough iron simply because of malnutrition or malabsorption, or both. And in the US, it's the infants, the children, and the elderly that are most susceptible and are most likely to have these kinds of problems. So any of you going into pediatric dentistry, or those of you who are going to spend a lot of time with patients that are in their 70s, 80s, or 90s, and that population is growing rapidly. In fact, I think after 2020, we'll have more 65 and over year olds than I think any other population in this country. But the point is that those groups are the most vulnerable because their diets are often not what they need to be to maintain the proper iron levels, okay? So under other conditions, so if the patient has some problems with GI systems such as chronic diarrhea, gastrectomy, that will affect absorption of iron. And finally, certain physiologic requirements increase in, for example, in pregnancy, if there's, so that can also lead to insufficient iron. So there are a number of different settings under which there may be a problem with iron insufficiency. So be aware of that. It's a relatively common problem, and we actually see manifestations of it in the head and neck area, not infrequently. We already talked about pathologic causes of blood loss. I'm going to give you guys a break. I know you're tired and you need 5 minutes or so, and then we'll talk about manifestations and then the other types of anemia. How far is that?
So it's right outside of Athens. So it takes us a little over 2 hours from there. So I read up there. Just change really quick. Hopefully I don't.
Okay.
I didn't want to be rude.
No, thank you for letting me know. All right, so let's talk about features that we see in the head and neck area, something that dental students, you're going to be in clinic very, very soon. And I hope this will help. So Detecting clinical features of anemia in the head and neck area, or any other area for that matter, can be difficult unless it's severe. It takes a lot before clinically it becomes more obvious. And in general, these are relatively nonspecific features. But whenever you see a patient with patchy or diffuse erythema, so what do I mean by that? You see red areas here, you see whiter areas here. This is what we call patchy erythema. There's a patch here, there's a patch here. It's not uniformly erythematous throughout, okay? And then the other thing you'll notice is that the tongue looks smoother than normal. So the filiform papillae are undergoing atrophy. And they're undergoing atrophy because they're getting not enough oxygen, okay? So tongue is the best place to look when it comes to intraoral features that have to do with anemia. So patchy and diffuse erythema. In this case, we have patchy. This is more diffuse. And atrophy of filiform papillae, where the tongue looks smoother than normal. And then complaints. Oftentimes, patients will complain of burning sensation of the tongue. That is a very nonspecific sign, but is often a sign found in anemic patients. Because the taste buds are not being provided with oxygen, taste alterations can occur. And then there is a feature that we see quite a bit. It's called fissuring of the tongue. And the fissuring of the tongue is also nonspecific. Just because you see all of these features doesn't mean the patient absolutely has anemia, but it's something to consider as part of your differential diagnosis. Fissuring of the tongue, which is difficult to see on this picture. I'll find a better picture next time. But it means you have sort of deeper grooves in the tongue when, so it sometimes will even look like cobblestone because of the deep grooves. And that's what we call fissuring. And that has to do also with various forms of irritation, which tend to occur much more significantly when a patient is anemic. Now, the problem with this is that, as I said, they're relatively nonspecific signs and can occur in other conditions. And the most common other condition in which we see these signs and symptoms is Candida infections. The most common oral fungal infection is a Candida infection. And and these features can manifest in Candida infections just like they can in anemia, which means when you see these kinds of features, at the very least, you should put on your differential diagnosis a Candida infection and anemia. And it could be both. So you have to test for both. All right, so this is perhaps the most characteristic and the most common way that these kinds of problems tend to present in the oral cavity. And we're talking about relatively severe and mainly iron deficiency, and also to some extent, I'll show you an example, megaloblastic anemia. Both of those can come with similar signs and symptoms. There's a very interesting syndrome called Plummer-Vinson syndrome, and almost every test has a question about Plummer-Vinson syndrome, which is why you need to know about it. It's a syndrome in which, besides iron deficiency anemia, which tends to be related to malnutrition or malabsorption, these patients also have glossitis, or inflammation of the tongue, and have dysphagia. And dysphagia, what is dysphagia? Inability to swallow or disrupted swallowing. Well done. Thank you. Drums, please. And the other interesting feature of this is typically Northern European women between 30 and 50 years of age that seem to be affected. Why that is, what's the underlying problem is still unclear. Just so you know that this type of combination of iron deficiency anemia with glossitis and dysphagia in Northern European women, 30 to 50 years of age. And the most important reason to remember this is because it does come with squamous cell carcinoma frequently. They have an increased risk, and I don't know why the spread is so big, between 5 and 50%. That's beyond me, but apparently the risk is much higher than in the average population. They can develop squamous cell carcinoma anywhere in the upper GI tract. That is the oral cavity, the pharynx, or the esophagus. So if you can put together, if you have a Northern European patient with these kinds of signs and symptoms, they need to be followed, and endoscopy is something that they need to undergo on some regular basis to not let the lesion become as big as this one. So this is a squamous cell carcinoma, an example of one in the anterior maxilla. You can see it occupies the entire space of central incisors, most of the vestibule next to the incisors, and extends way back into the palate. So it's a large lesion, and this isn't the only way they present, but this is one example of what squamous cell carcinoma looks like in the oral cavity. Okay, so important syndrome to remember. Any questions? All right, so let's talk about other forms of anemia. Not mechanistic classification, it's the second one. It's anemias of decreased production. And we're not going to be talking at this point about iron deficiency. We're going to be talking about all the other forms of decreased production. So how do you lose production of cells? Well, I already mentioned before that there are a couple of vitamins that are very important for cell division and differentiation. And so vitamin B12 and folic acid are important for DNA synthesis. And when they're deficient, patients will develop megaloblastic anemia. So the umbrella term is megaloblastic anemia. And it encompasses all of these, no matter what the B12 deficiency is due to, what the folic acid deficiency is due to, and it's more often B12 than folic acid that the problem is. It's all going to be megaloblastic anemia. And then there are certain specific ones that belong in that group, and we'll talk about one example of that called pernicious anemia. And that ties together autoimmunity, GI tract, and blood system. And you'll see how that all works together. We'll talk about it specifically. The other way you can end up with an anemia of decreased production, but it's not going to be megaloblastic anemia, it's going to be defective hemoglobin synthesis. And that's a genetic problem. And there are several things that can happen to the genetic apparatus that encodes the alpha and beta chains of the hemoglobin genes. So the example we're going to focus on is going to be thalassemia. There are several different types of thalassemia. I'll give you all of that nomenclature, but we'll focus mainly on the features and what's the underlying problem. And finally, one that I already mentioned earlier is a defect in the hematopoietic stem cell, so that the pluripotent stem cell is damaged either by viruses, viral infection, by toxins, by certain drugs, leading to compromised or inability to produce any of the blood cell types. So the blood cell numbers drop precipitously and every group is affected. So let's talk about the first one, the B12 deficiency, megaloblastic anemia due to B12 deficiency. So remember, this is just a little bit of background on what vitamin B12 is about. Synthesized by bugs, diet matters. You do want animal sources of food because that's where you get the best B12 supply. But you can also go to the store and get one of those bottles with B12 synthetically produced. And in fact, it's more and more common that patients are put on B12 supplements because problems with B12 deficiencies affect many different things. And the older the patients get, the more likely they are to have this problem. And they will have not only potentially signs of megaloblastic anemia, but also some other problems. So B12 is actually prescribed on a frequent basis. Now, so besides not getting it enough through diet, there are certain intrinsic systems. So, for example, in the gut, you will remember in the stomach lining, in the fundal area of the stomach, there are cells called parietal cells. Remember that? Those are the source of intrinsic factor. Remember that? And why do we need intrinsic factor? It's one of the key molecules that has to bind B12 to deliver it to the right receptors in the ileum so that the B12 can be absorbed. Without the intrinsic factor, there's very little B12 that gets absorbed, very little. There's some still absorbed, but not very much. So if the parietal cells are gone, and you can imagine, give me an example when the parietal cells might be unavailable. Ulcer, let's say that whole area of the stomach is being damaged, okay? What about an iatrogenic problem? Let's go with iatrogenic for what can doctors do to the stomach? Remove it, right? You can have a gastrectomy. And so that can lead to, obviously, loss of parietal cells and intrinsic factor. So, and under the condition that we're going to talk about, called pernicious anemia, it's our own immune systems that target the parietal cells and destroy them. So an autoimmune condition called pernicious anemia means that parietal cells are being destroyed, intrinsic factor is no longer made. And then there are other aspects of that disease is that the people with pernicious anemia also make antibodies against certain molecules that interfere with absorption of B12. So it's a complicated system, but you have to remember that it's an autoimmune disease and it's only one type of megaloblastic anemia. Pernicious anemia is only one type of it. Okay? So what do we know about it? So it's vitamin B12, also known as cobalamin, not being absorbed for these reasons, and I told you about the reasons. And these patients will typically have a form of gastritis called atrophic gastritis. And what does that mean? What does gastritis mean? Inflammation of the stomach lining. And what does atrophic mean? Reduction in size, right? Reduction in cell number and size. So atrophic gastritis means you're losing cells and you have inflammation. All right, and that's characteristic of this type of anemia. So you start with this problem, which leads to the anemia, okay? This is where it starts. The stomach is the problem. And of course, anybody remember what the common signs of anemia are? Fatigue, weakness, headaches, lightheadedness. Yeah, pale tissues, yes, excellent. What about the tongue? What might you see? Patchy or diffuse erythema, right? What happens to the filiform papillae? Atrophy, right? So same as atrophic gastritis, you see some atrophy of the filiform papillae. So all of that still fits together very nicely with the picture you get lower down in the GI tract. But there's an interesting feature that you don't see with other types of anemia that comes with vitamin deficiency, B12 deficiency. It's called symmetric paresthesia. What does symmetric mean? Both sides, right. Paresthesia, altered sensation, right? So in this case, it presents as tingling or numbness. And it's going to be pretty much in the extremities. So for some reason, and the mechanism is really still not understood, it is thought that it has something to do with myelin, that lack of B12 affects production of myelin, so the conduction isn't very good. And so then sensory nerves have a problem and you get numbness or tingling sensation. And it's typically hands and feet, or sometimes just the hands, okay? Unique to megaloblastic anemia, particularly B12. You look at the patient clinically, you pretty much can't really tell the difference. It looks like pale, maybe diffuse erythema, maybe some fissuring, as you can see here, there's some fissuring. The one thing that you might see with pernicious anemia that you won't see with iron deficiency anemia is somewhat yellowish coloration of the skin. And that is unique. It's different from what, we don't see that in iron deficiency anemia. So here's an example. All right, so let's look at one case quickly. So this is a 64-year-old man, and he presented to a clinician at the University of Louisville. And his chief complaint was something that we see a lot in the dental office: burning sensation of the tongue and dry mouth. Very, very common, especially in this age group. The guy underwent a very extensive workup. They ended up thinking that this is non-specific dry mouth, and he was treated with a medication that stimulates saliva flow. You'll hear a lot about dry mouth because it's a very common problem. For the purposes of this course, we're not going to focus on it. The only thing I'm going to say is dry mouth is commonly a consequence of anemia, simply because anemia is not providing, the blood isn't providing enough oxygen to the salivary glands, therefore they're not producing enough saliva. Okay, so that makes sense, right? That's logical. Well, so here was the blood test. So finally so Dr. Bernstein was the one who decided to do a blood test, which is something you always have to keep in mind. If a patient presents with these relatively nonspecific signs and symptoms, think of anemia as part of your differential diagnosis. So they look at his white blood cells. This is typical panel here, some counts, cell counts, and some additional tests for iron levels and vitamin levels. And what they found was that while their lymphocytes were just about normal, barely, red blood cells were reduced below normal. And by the way, something I didn't mention before is that depending on the lab you send the blood to or other fluids for analysis, they run their own panel, normal panel. And for each individual lab, the range of normal might be a little bit different. It has to do with the kinds of patients that tend to be in that area, live in that area, or it can have something to do with the type of instrumentation that's used in the lab. So you'll see some variation, but they will always provide the normal range, so you can see in reference what your patient's results, how they fit the normal values for that lab. So clearly red blood cells are reduced. Hemoglobin level was just about at the cutoff for a male. Remember, 13 grams per deciliter. It barely makes it into the normal range. Mean corpuscular volume and mean corpuscular hemoglobin are both high, which would, just from that standpoint, would tell you that the cells are bigger than normal and have more hemoglobin than normal. But altogether, it all amounts to the patient being anemic because overall the cell numbers are low. Of course, they looked at iron and the storage, so ferritin and iron are within normal limits. Folic acid was normal, but vitamin B12 was severely reduced. And there's your answer. It's not clear why, at this point, this patient has low vitamin B12. It could be for a number of different reasons, one of which could be pernicious anemia or autoimmune destruction of the parietal cells of the stomach, which turned out to be the case because further workup actually found that this patient had atrophic gastritis and antibodies that are consistent, immune parameters that are consistent with this disease. The good news is it's easy to fix. So all you have to do is provide some injections. So the physician prescribed some injections, and only within 2 weeks his B12 levels were back to normal, and very quickly his anemia was becoming corrected, the burning sensation was gone, and the other good news is you can maintain this by giving very high doses of oral B12. They don't have to get injections for the rest of their life. So they can get that bottle I showed you. They can go to the supermarket, get themselves some B12, and take very high doses. And only a small amount of that will be absorbed, but it's enough to maintain the levels. Okay? So very easy fix, as long as you make the diagnosis. But that's the point. You have to make the diagnosis. So you have to know where to look, and you have to know what tests to order, and what kinds of practitioners to work with to make sure the patient gets the help they need. Okay. So let's talk about other types of anemia. I told you that I'm going to talk about one of these genetic anemias that have to do with abnormal hemoglobin production. Well, these kinds of conditions, actually, as a general rule, they're called hemoglobinopathies. Thalassemia is one of them. And they're actually quite common, especially in the Mediterranean, African, Indian, Southeastern Asian populations. And the reason these things are common is because they're actually protective against malaria. And we'll talk a little bit more about this in a minute. But when it comes to thalassemia, one interesting thing about it is it kind of straddles two categories. You see, I put 2 plus 3 here because it not only has features that are decreased production, abnormal production of hemoglobin, but also increased destruction. The cells that are being made can also be more susceptible to destruction, and therefore some hemolysis does occur in these patients. But the main problem has to do with the fact that there are mutations in either the alpha or the beta globin genes. And depending on where the mutations are, how many alleles are affected, you get different manifestations, more severe, less severe. So what's made is abnormal hemoglobin, and the abnormality is not in the heme group, not in the iron, but it is in the protein itself, all right? So I already told you this. So in a minute we'll talk about the specifics of this disease, but I wanted you to first see what they might look like in the relatively severe cases when they present to a dental practitioner. So in a dental office, it's not unusual, especially in the orthodontic clinic, to do cephalometric radiographs if the patient needs orthodontic treatment. And it's typically a lateral skull film, and you can see, so this is the skull of a patient that has thalassemia. It's a young child. And you can see that instead of a smooth cortex, they have this spiky appearance. So this has been called hair on end or crew cut type appearance, okay, because of this very spiky appearance. And this is very characteristic of both thalassemia and to a lesser degree of sickle cell anemia because they have rather similar underlying mechanisms. And the features that are often asked about on exams is recognizing that there's a prominent forehead called frontal bossing. There is this hair on end appearance of the surface of the skull, also known as calvaria, and the jaws become enlarged. And the jaws are enlarged because of the process that's going on in the bone, presenting as a honeycomb pattern. Okay, there are little sort of radiolucent areas separated by septi, sometimes appearing a little bit like a honeycomb in a beehive. And what's going on in those areas is extra bone marrow. Normally, we don't have hematopoietic marrow in the jaws by the time we're, a few years old. But these patients have a lot of these areas, and they're very easy to see on radiographs. So the jaws are enlarged, and they're enlarged because there's extra bone marrow in these areas. There's also extra bone marrow in the skull itself, and that's partly responsible for this hair and end appearance. So why is that? Well, the problem with, just as a general statement, just a general feature, is that the cells that are being made in patients with thalassemia and also in sickle cell anemia are not very good. They don't last very long. They can't do their job. There aren't enough of them. And so the system tries to compensate for that by making more and more, putting marrow in more and more places. So they end up with marrow in bones that don't normally have bone hematopoietic marrow. And they also use their liver and the spleen, which is only used in the fetus normally. But in children with this disorder, even the liver and the spleen have areas of hematopoietic marrow. Okay, so all of those organs, bones, liver, and spleen, are involved in hematopoiesis, and they become enlarged. All right, all because the system is trying to compensate for poor quality of the red cells, really poor quality of the red cells. So let's go a little bit over the genetics. I'm not going to spend a lot of time on this, but just so you remember, hemoglobin that we normally, most of our hemoglobin is called hemoglobin A, adult hemoglobin. It's a tetramer. There are 2 alpha chains and 2 beta chains, and they're encoded differently. The alpha chains have 2 genes, and the beta globin chain has only 1 gene. And depending on where the mutations are and how many alleles are affected, you get, and what kind of mutation it is, you get somewhat different kinds of thalassemia. So you'll have to remember that thalassemia major is one of the worst kinds of thalassemias to have. It leads to very severe deficiency because either they don't have any beta chains at all, so beta 0 stands for the mutation does not allow any production of beta chains. Beta plus means it's mutated, but so it's abnormal, but it's still produced. So any of these configurations, 2 beta zeros, beta 0 and beta plus, or beta plus, all of those lead to this form, thalassemia major, a very severe kind of thalassemia. Another form of thalassemia called thalassemia trait, which has relatively mild manifestations, has this kind of configuration. So at least one of the beta chains is normal, the other one is mutated. It's either missing or it's abnormal, okay? The big problem with beta thalassemias is that not only do they have less hemoglobin in general, but the alpha chains, because they don't have enough betas to pair with, they end up precipitating. And that affects cell morphology and function and makes them very susceptible to being lysed, which is why you get that other part, the increased destruction part, along with decreased production. Okay, does this make sense? Yeah, everybody? Okay. All right, so that's on the beta side. And so again, with thalassemia major, it's really bad and transfusions are necessary. With the trait, you basically have a microcytic anemia, so the cells are small, can be hypochromic, but it's relatively asymptomatic because it's not a very severe problem. Okay? In alpha thalassemias, the problem is somewhat different. First of all, if there are no alpha chains, because both the genes are completely disabled, it's fatal before birth, and it's called hydrops fetalis. And then there are other three forms: hemoglobin H disease, alpha thalassemia trait, and finally silent carrier. And you can just look at these and think about exactly what this all means. It's all pretty self-explanatory. You have to just remember that hemoglobin H is moderately severe anemia, in a way somewhat similar to beta thalassemia major, and the trait is less severe of a problem. A key feature to remember here is that even when you don't have enough alpha chains to pair with the beta chains don't create as much of a problem as the free alpha chains, because the beta chains can still form stable complexes. And that's what it means, hemoglobin H disease. Hemoglobin H are paired beta chains. And they're stable. Alpha chains precipitate, free beta chains don't. They form hemoglobin H, therefore the problem is less severe and potentially leads to less hemolysis. Okay? So alpha thalassemias and beta thalassemias with somewhat different manifestations and different severity. Okay. Now, remember this one form of it, the beta thalassemia trait, where you have one normal beta and one abnormal or missing beta. Asymptomatic microcytic anemia, because of that, can look a little bit like, or much like, iron deficiency anemia. And when it's misdiagnosed as an iron deficiency anemia, because someone didn't pay close attention, they are going to get too much iron. You can't give them iron, because these people are very easily go into iron overload because of the way their absorption of iron works. And so they can end up with a really bad problem called hemochromatosis. So they can't have more iron. You can't supplement iron for thalassemia patients. You can end up with a worse problem than they have already. So these patients do need more extensive testing, and among them they look at hemoglobin, so you use electrophoresis to do that, and they do genetics. And genetic counseling is also important in these patients, because if two parents have a beta thalassemia trait, the child has a 25% chance of thalassemia major, and that's not a good thing to have. Okay? So all of this can be diagnosed in utero, so they can do both hemoglobin electrophoresis and genetics to find out if the patient has any of those risks. Okay? So this is an example of a genetic disorder affecting the beta globin genes in one or more way that leads to different type of anemia depending on the severity, one of which can be a microcytic anemia, and other more severe anemias can be both microcytic and also have hemolysis along with them. Okay, any questions? No questions? Okay. All right, so let's talk about stem cell defect. This is one of those misnomers we talked a little bit about earlier. Precursor cell has failed. It has failed maybe because the patient was taking certain antibiotics. Some antibiotics can do this. Clindamycin, for example, has been known to induce defects in stem cells, sometimes the pluripotent stem cell, sometimes the more differentiated stem cells. So drugs do it. Antibiotics do it. Every time you look at medications, you have to prescribe a medication for someone, look at the adverse effects. Always keep track of the adverse effects that these meds can have, okay? Because if that cell fails, all blood cell types fail. Can you name them? Can you name all the blood cell types? or at least the important ones. I'm sorry, what's that? Oh, you're giving me groups, blood cell groups. I'm talking about blood cell types. White blood cells, and how many white blood cell types do you know? Lymphocytes, right? What kinds of lymphocytes do you know? T cells, B cells, natural killer cells. Okay, those are your major lymphocytes. How about myeloid lineage? Neutrophils, basophils, eosinophils, monocytes, macrophages, mast cells, although they become mast cells once they get out of the blood. Anything else? My favorite cell, come on. Dendritic cells, right? Dendritic cells, they're also myeloid. Well, there's a lymphoid lineage too. Okay, so all of those get wiped out. What other cells do we know in the blood? Platelets and red blood cells, right? Okay, so every single one of them is affected, every single one. And the general, so it's not particularly clear. Some labs, some people use different numbers, but in general, most people will agree that if the granulocytes, which is neutrophils mostly, some eosinophils and basophils, which are in minor numbers in the blood, most of them are neutrophils, right? If they drop below 500 cells, 500 granulocytes, sorry, per microliter, I gotta go and fix this. That's really low, and that's considered at the point where aplastic anemia is a consideration. If it's less than 20,000 platelets, which normally is between somewhere 150,000 to 450,000, that's considered way down there, possibly consistent with aplastic anemia. And reticulocytes. Remember what reticulocytes are? Immature red blood cells that are already in the bloodstream that still have remnants of nuclei in them that are larger than red cells. Okay. All three, if all three numbers go down, that's when you're thinking aplastic anemia. If just one of them goes down, it's a different problem. But when all three go down, aplastic anemia is your choice, okay? All right, so obviously, because red cells take care of oxygen carrying capacity, you're gonna have features of anemia. Obviously, because platelets are responsible for hemostasis, at least part of the hemostasis system, you get bleeding disorders. And finally, because white blood cells are wiped out, clearly these patients are also susceptible to infections. So it's really bad news. Everything is affected and really badly, okay? Very serious condition, nothing to laugh about, medical emergency. How do they present? Well, they actually can present in the dental office, and in the dental office, you'll see features of anemia are going to be, like always, somewhat difficult to pick out. You know, being able to say that the tissues look pale, yeah, I mean, you might be able to, and sometimes you can't. But you will see bleeding, evidence of bleeding, because losing that many platelets, going below 20,000 platelets, when normal lower cutoff is 150,000, that's a severe reduction, and therefore bleeding is a problem. And we'll talk about specific types of bleeding that are characteristic of platelet problems. The terms I put in here are actually the characteristic terms. Mucosal petechiae, purpura, and ecchymosis are the three major types of bleeding manifestations that we see with low platelets. What are those? Petechia are about 1 to 2 millimeters in diameter. Purpura is about 5 millimeters in diameter, and ecchymosis is anywhere from 0.5 to 1 centimeter, or even up to several centimeters if they're flat lesions. Each one of these tend to be flat. There is no significant increase in tissue thickness, okay? When you do get increase in tissue thickness, you also get inflammation, which is part of the problem. But the most important thing is you get petechia, so you see 1 to 2 millimeter. Purpura, this is about half a centimeter, and then ecchymosis, a centimeter or higher. All of those are characteristic of a platelet problem rather than coagulation factor problem, which we'll talk about in a bit. Some gingival enlargement, it can be related to inflammation. It can also be related to susceptibility to infection. But you get ulcers, and ulcers are characteristic of this condition because these patients are susceptible to infections. And these ulcers, see the one in the corner of the mouth here? They tend to be crater-like. So they're deep ulcers with a lot of deposit on the surface. A lot of this is bacteria because the immune system isn't working properly. There are not enough cells to deal with bacteria. And they can be either on these kinds of mucosal surfaces or on the gingiva. In this case, we don't see gingival ulcers, but we do see an ulcer at the corner of the mouth. Okay, so evidence of anemia, and there will be, of course, systemic manifestations, lightheadedness, headache, weakness, fatigue, etc. Evidence of bleeding and ulcers. All of those together constitute enough signs and symptoms coming together to suspect that the patient might have aplastic anemia, and a blood test is essential. Okay? Okay. So that's kind of an outlier. It's not just red cell problem, it's every kind of cell problem made by the hematopoietic system. Okay? Next group, increased destruction. So these are called hemolytic, and it's that third group in the mechanistic classification. I already showed you what thalassemia can do. It has more features related to decreased production, but also some features of increased destruction, such as marrow placed in unusual places, as well as occasionally cell lysis. But the best example, a more pure example of anemia of increased destruction is sickle cell anemia. And we'll specifically talk about sickle cell anemia. And these groups of these conditions, such as thalassemia and sickle cell anemia, have to do with a problem with the cell itself. So the red blood cell is abnormal, therefore it's called an intrinsic or intercorpuscular problem. But you can also have destruction of red cells because of something else. The cells are normal, red blood cells are normal, but something else is going on in the system that's attacking the red cells. And the one condition that we'll talk a little bit more when we talk about autoimmune disease is called autoimmune hemolytic anemia, and we'll also see it in the context of other autoimmune conditions such as systemic lupus. And these are called extrinsic or extracorpuscular because the problem is not with the red cell itself, but elsewhere, either with the immune system or some other problem is happening and causing cell destruction. Okay, so for the purposes of just looking into what happens with the patients when they have hemolytic anemia, we'll focus on sickle cell anemia. So, first of all, what does it mean in terms of the red cell itself? Well, it's being destroyed before it's senescent, before it's run its lifespan. So the lifespan is shortened, and because of the lysis, which can occur both in the bloodstream and in the spleen, products of hemoglobin catabolism accumulate just about everywhere. They accumulate in the spleen, they accumulate in tissues, they accumulate in the blood, and they can spill into the urine. So you have manifestations of that in all sorts of compartments. Because the cells don't live very long, in order to make up for the deficiency, you need to make more of them. So increased hematopoiesis. You have more bone marrow. Again, just like I showed you with the patient with thalassemia, sickle cell anemia patients will also have extra, what's called extramedullary hematopoiesis, either in liver, spleen, or in certain bones that normally don't have hematopoietic marrow in them, such as jaws, okay? The classic feature that comes with this kind of anemia is jaundice. Of course, you know that it comes with other kinds of conditions, right? What else causes jaundice? Liver disease, right. But it's also a very important feature of hemolytic anemia. Now, in the case of hemolytic anemia, it's because hemoglobin spills into the tissues, undergoes catabolism, and bilirubin accumulates in the tissues as a result of that. And the best place to look for jaundice is not in the oral cavity, it's in the sclera. So you see yellow sclera, especially because people have different amount of melanin pigmentation in their skin. That can make it difficult to evaluate too. But in the sclera is always white in normal people. And when it turns yellow, that's when you know the patient has jaundice. Whether it's because of liver disease or because of hemolytic anemia, that's the next step, figure out what caused it, okay? They'll still have the same common features of anemia, but they also will have, at least early on, and in sickle cell anemia, just like in thalassemia, early on, in early stages of the disease, splenomegaly is going to be very prominent. It's enlarged because, A, the cells are being pulled out of the blood very quickly, so there's a lot of them accumulating, being destroyed in the spleen, but also because there's hematopoiesis going on at the same time. If you see yellow coloration of the soft palate in a patient, but no yellowness of the sclera, then your first choice would be actually increased keratin in the blood rather than hemolytic anemia, hemolysis. For some reason, people who eat too many carrots, shrimp, tend to deposit keratin, and so it, for some reason, accumulates in the soft palate. So don't alarm the patient, but ask them about their diet. It's not hemolytic anemia. I already showed you one of these earlier, so you can see sickling. So if you were to look at a smear of a peripheral blood smear from a sickle cell anemia patient, you'll see this very classic shape, sickle shape of some of the red blood cells. Now, most of the time, while they're not in crisis, the number of these sickled cells is going to be small. But the problem is there are a number of things that can precipitate rapid sickling, and then a lot of the cells become sickled, and that's where major problems begin. All right, so, but even under normal circumstances, when the patient is not in crisis, if you look at their smear under the microscope, you can see some sickle cells, as well as some other features, abnormal shapes, abnormal size, some increased variation in size, and variation in shape. So anusocytosis, poikilocytosis are the two things you see even in patients that are not in crisis. Now, just as a general thing, so when you think about it, well, thalassemia has, let's say beta thalassemia, has mutations in the beta globin gene, and why does it look different, that clinically often presents different than sickle cell anemia? Because sickle cell anemia also has to do with mutations in the beta globin gene. Well, the difference is that while in thalassemia, the mutations in the beta globin gene will lead to either reduction or lack of, let's say, beta globin. In the case of sickle cell anemia, these mutations lead to abnormal beta chains that cause the cells to aggregate, and the polymerization of these chains ends up changing the shape of the cell. So the type of mutation in the beta globin genes in sickle cell anemia doesn't lead to reduction. It leads to a malformation, okay? And these cells are much more likely to change shape under stressful conditions. So in the interest of time, I'll just let you read some of this on your own, some of the statistics and things. But in case of a patient, let's say in the dental office, what you might see is something that looks similar to thalassemia, but perhaps less pronounced. But then you'll also see features, some features that are not characteristic of thalassemia, and I'll explain why that is. So here is that hint of hair-on-end presentation of the calvaria. So you can see that in sickle cell anemia. It tends not to be as pronounced as in thalassemia. And the thing that you don't see with thalassemia as much is you see delayed dental eruption and hypoplasia, underdeveloped teeth in patients with sickle cell anemia. The reason that you see some of these features, including ischemic necrosis in sickle cell anemia, is because when the cells sickle, especially under these stressful conditions, and there are a number of them that are created in the dental office, and we'll talk about those in a minute when we talk about crisis, is that when these cells change their shape to a sickle shape, they stack. They tend to stack and form kind of like a coin stack, and they stick to each other. And when they do that, they block vessels. They block small vessels, which means anything downstream doesn't get blood supply. And it stays there long enough so that it causes necrosis of the tissue downstream of the plug, okay? This is something that never happens in thalassemia. It only happens in sickle cell anemia because the mutation is different. It affects the beta chain differently than thalassemia mutations do, okay? And so delayed dental eruption, hyperplasia of teeth, underdeveloped teeth, generally growth retardation are much more severe in sickle cell anemia because of this added problem of stacking of the red cells causing ischemia and necrosis downstream of the plug, okay? That's the big distinction. So I told you that every now and then these patients can present relatively normally, at least initially, but there can be a crisis. So under sickle cell crisis, what do we see? Well, first of all, they can be precipitated by hypoxia. They can be precipitated by an infection. They can be precipitated by low temperatures, by lack of fluid, so dehydration. And then there are other things that we don't even know about. There are a number of things that can precipitate the crisis. Sickle cell crisis is a major problem. And by the way, the case that I posted from New England Journal of Medicine is a description of one of such crises. A patient, a 22-year-old man with sickle cell anemia who had a crisis that led to infarcts in the brain. They last several days. They can last anywhere from 3 to 10 days, depending on how severe the precipitating factor was. And the big problem during the crisis is exactly what I was just telling you about, is the blockage of capillaries. So many different capillaries can get blocked. And you can imagine, if this happens in the lung, if this happens in the kidney, can you imagine all of those organs undergoing severe dysfunction because no longer capillaries are supplying blood to the tissues. So you get ischemia, meaning low blood supply or no blood supply, and then infarction, meaning coagulative necrosis downstream of the blockage. And this is extremely painful. So they get severe pain, and In addition, these cells are shaped so abnormally and they're so rigid at that point that when they go through the sinusoids of the spleen, they get destroyed. So they get lysed, and so you get features of hemolysis. And when you have hemolysis, you not only have anemia, you also have jaundice, okay? And where do we look for jaundice? In the sclera, okay? Now, if there is also a component of infection, which can easily happen under these circumstances, they may also experience fever. So, very severe problem and potentially fatal problem. So, there's effect on bones. I already told you about the effect on dental development. You know, you have either undeveloped or slow development of teeth and the maxillofacial apparatus in general. Of course, there's very severe effect on all sorts of bones. In the child, you can imagine growth plates are affected, so growth is affected. Lungs, I already mentioned that. Can you imagine blocking the capillaries of the lungs? That cannot be good. Liver, brain, anywhere, spleen, everywhere this can happen. And because this happens in bones too, bone pain actually is particularly common in children for some reason. So it's a very, the symptoms are severe. Stroke, the case I posted, has to do with this type of crisis. And then, of course, if the lungs are affected, you can end up with, obviously, cough, chest pain, infiltrates and inflammation in the lung. And this can lead to cor pulmonale, which is an important sequela to remember of a sickle cell crisis. Okay, you probably heard about this in the cardiovascular and pulmonary lectures. Okay? All right, so very serious problem, very, very serious problem. So what do we do? Oh, one thing I should remember to tell you is that early on, the spleen just gets enlarged because you have a lot of abnormal cells accumulating in the spleen because they're being taken out of the system since they're abnormal. But so initially, these patients will actually have splenomegaly, an enlarged spleen. And because they will also have hematopoiesis in both spleen and liver, which means these organs are going to get bigger. But the spleen doesn't stay large forever. Because of the repeat accumulation of these, the repetition of the cycles of plugging and ischemia and necrosis, they eventually develop autosplenectomy, which means you can see the result. This is a totally abnormal spleen in a patient who's had crisis after crisis, and you can see only a little bit of splenic tissue is left, and the rest of it is shriveled up connective tissue with areas of inflammation. This is what they call a splenectomy, meaning that normal splenic tissue has been replaced by fibrous tissue, and so the spleen no longer does its job, okay? We'll talk more about what happens if patients don't have normal spleen function, whether it's autosplenectomy or it's another cause when we talk about white blood cell disorders. But keep in mind that this is a very important problem for these patients, and the only thing I'm going to say now is they're very susceptible to infections, particularly bacterial infections with encapsulated bacteria that tend to head straight for the bloodstream when they infect us. So, for example, Haemophilus influenza is an example of that type of bacterium. It's an encapsulated bacterium to control which we have to have good spleen function because it gets into the bloodstream very easily, and the bloodstream is basically handled by the spleen but not the lymph nodes. So you have to remember that they're very susceptible to infections with especially encapsulated bacteria. So these patients have a lot of different problems. They need a lot of dental care. and we have a lot to think about when we try to provide them with help, because current treatments actually allow survival past age 50. So they can live a long time and need a lot of very special care for a very, very long time. Okay? I'm listing here a few other anemias that you should know about, hemolytic anemias, because they affect dental management, but I'm not going to test on these, but I want you to be aware of them. Also, you can see hemolysis under other conditions, iatrogenic conditions. So trauma to the blood cells can occur if patients have a mechanical valve, for example, heart valve. You know, opening, closing, it kind of slams on the red cells and causes them to lyse, obviously. So you can have some intravascular hemolysis and a little bit of jaundice in those cases. So don't be surprised if you see that. We'll talk about immunohemolytic anemia, as I said, during autoimmune, when we talk about autoimmune disease. And the rest of the red blood cell stuff, I think you should just read on your own. It's just lists of stuff, just talking about increase in cell number and polycythemia being the term for increased cell number. And this is all very self-explanatory, so I don't think you need to get too hot and heavy on this, and I'll let you just read about that. But at the end of this lecture, I actually have a few pointers on study questions, so you need to know what these terms mean. Can you provide examples of anemias that fit into these categories? And do you know the mechanistic classification? And can you describe these features and explain why blood tests are useful and what parameters on the CBC might be abnormal under these circumstances? So that's all for the red cell stuff that I have for you. And I want to spend some time on bleeding disorders for the rest of the lecture today. Any questions? No? Okay. All right, do you guys want a break and then we can talk about bleeding? Okay. No. Okay, I'll just get you a little bit in the mode. Try not to do too much on bleeding, but I'll try and just hit the highlights, and the rest you can read on your own, because I know you like reading on your own, right?
Oh, yeah.
Very much so. All right, good. All right, goals and objectives, always there. So what I have in this PowerPoint here, and you have the PDFs. Overview of normal hemostasis, which I won't hit very hard. I'll just touch on a few things because it's all there. You can read it. But I'll only mention a few things that are important for the specific abnormalities that we're talking about. And then I have information on the various abnormalities that affect hemostasis. All right, so this goes without saying. Everybody knows that as a dentist, there's going to be a certain percentage of patients, 5 to 10% actually, that have bleeding problems, and it's better if you know you're ready for this before what they say, whatever that is in quotes hits the fan. You don't really want to be there, right? So let's be prepared. And so what do we need to know? So first of all, when it comes to diagnosis of bleeding disorders, it's not unusual at all that it's an incidental finding in a lab test, or something happens in the dental office or in some sort of surgical procedure where suddenly the patient has a bleeding-related problem, and nobody ever knew that there was a problem to begin with because the patient was, prior to that, asymptomatic. But every now and again, so these are the more common circumstances. These are the more common scenarios. It's less common among these problems that the patient actually does have a personal or family history of excessive bleeding. So there are certain definitions and terms that are listed here. You need to know them. And I'm not going to spend time on reading them to you, but you are still responsible for them. So, what are the most important things that contribute to hemostasis, to normal hemostasis, maintaining the blood flow without spilling the blood outside the vessels? Of course, it's the blood vessels, of course, it's the platelets, and of course, it's the coagulation proteins. Everybody knows that. So we're going to look at the certain different parts of this. So how does this all work in a nutshell? So as an overview, you have a blood vessel. It gets injured. Usually the injury is to the endothelium, and there are many injuries that happen during the day, somewhere along the vessel wall. There are minimal injuries that don't go unnoticed, so we form clots on a regular basis just because of these little tiny injuries to the endothelium. So it always starts with some sort of injury to the vessel. And then you have certain steps that control the problem, prevent bleeding. So you have vasoconstriction, which is a neurogenic part. Then you have platelets, which adhere to the exposed collagen of the vessel wall. Then you have platelets activating because they adhere to the collagen. And finally, that ends up with a coagulation cascade with a permanent fibrin platelet, semi-permanent fibrin platelet clot, which then finally undergoes fibrinolysis, because you can't have clots in the vessels staying there forever, because at some point you're going to just cut off the blood supply to your organs and tissues. Therefore, the clots have to go away. But it all has to be very timely and well sequenced, and so our systems are very good at, in normal circumstances, at managing this without panicking, all right? So everything gets taken care of for the most part. So, important to remember that the lining of the vessel, the vascular endothelium, when not injured, has anticoagulant functions, and when it is injured, it's procoagulant. It functions to stimulate coagulation, right? So I'm not going to go through these. You can read this. This is a background information that you probably should remember from your previous courses, what happens with platelets, how they get activated, and This already, yeah, and these are the platelets right here, okay? These tiny little guys. They're much smaller. They're about 3 to 5 microns. They're much smaller than any of the other cell in the blood. All right, so these are the diagrams that will help you just follow the scenario. So here is a situation where the endothelial lining got injured. The platelet is adhering to the connective tissue underneath, which happens to have von Willebrand factor, and this is a very important part to remember, and that's why I'm bringing it up here. This von Willebrand factor is produced by the endothelial cells, and it only makes things work as far as getting platelets to adhere when it's exposed like this because the endothelial lining is injured, okay? So that's what triggers adhesion and then finally aggregation of platelets. All right, so the take-home message from here is this is one coagulation factor that's not produced by the liver. It's produced by the endothelial cells. And manifestations of abnormalities, which is when the most common coagulation factor abnormality is related to deficiency in this factor, manifests more like platelet deficiency than it does like a coagulation factor deficiency, but it has features of both. So it stands out among all the other coagulation factors, which is why you need to know this scenario so you can understand why it's different. Okay? So it works with the platelets at the initial stages of platelet adhesion. All right, these are some additional details on what makes platelets activate. You just need to be aware of them. And you also need to remember that when it comes to that next phase of coagulation, the platelets have attached, they have adhered to each other, they aggregated, and now the coagulation cascade begins to make this more permanent plug, which is actually semi-permanent because eventually it has to get dissolved. But this is the step where coagulation cascade can be triggered either by intrinsic or extrinsic factors. And no matter which way it starts, whether it's tissue damage extrinsic or intrinsic, it all ends up with a common pathway, okay? And this is where all these other coagulation factors are important. And they're all produced in the liver. So von Willebrand factor is not part of this cascade, okay? Bottom line, these are just the main points that you need to keep track of because it helps to understand the abnormalities. During this coagulation cascade, you have calcium that's very important, it's critical. All factors except von Willebrand factor made in the liver, I told you that. And then there are these other factors which are vitamin K dependent, which means we need our vitamin K, which of course you'll remember are produced by our intestinal bacteria, E. coli, and you need your green leafy vegetables. Everybody having green leafy vegetables for dinner today? Okay, good. All right, so you need your vitamin K so your liver can make vitamin K dependent coagulation factors, and your E. coli will be happy too. All right, so this is the composition of the clot. In the end, this is what you have. So this is the semi-permanent clot. This is your exposed connective tissue, wall of the vessel. These are the endothelial cells, and here are your platelets, and they're adhering to the wall, they're adhering to each other, and this red stuff in between is the fibrin. So the fibrin is the result of coagulation cascade, which allows, it's like cement binding together the bricks. Platelets are the bricks, and fibrin is the cement. But along the way, a few other cells get trapped. You get some red cells, you get some white blood cells. They kind of get pulled into the mix every now and then, maybe because they just stood around too long and they were gawking at the problem, and so they got roped into the problem. But they are not really contributing anything. Okay, so that's your clot. So think of it like this. So the very first step, when the platelets adhere, and the reason they adhere is they're trying to plug the hole, okay? That's the very quick and dirty way for them to plug the hole. So let's say you have a problem in the kitchen, there's a leak in the pipe under the sink. The first thing you think of is whatever's sitting on the counter. It might be bread dough, if any of you bake bread, or whatever it is. You can quickly plug it up. It's nice and sticky. It's going to potentially close, but it's not going to last, right? That's all your platelets can do, is to quickly stick there and plug the hole. If the clotting coagulation cascade doesn't step in right after that, you won't have a semi-permanent solid plug, and the leak will begin, okay? So think about it. Platelets do the immediate early hemostasis, but they're weak. They can't hold it together very long unless coagulation factors come in. So if you don't have good platelets, you can't stop the leak quickly, so you're going to have a few small bleeds. I'll keep reinforcing this, keep reinforcing this. But if you have good platelets, you won't have early bleeds. They're going to stop the hole. On the other hand, if you have good coagulation factors and bad platelets, not enough platelets, they don't work very well, they're kind of lazy, then what you'll have is early bleeds, but the coagulation factors will make up for the deficiency, and you'll eventually stop the bleeding, so the bleeding won't last very long. So these are going to be small bleeds because it's the platelets that aren't doing their job properly, but the coagulation factors are working. On the other hand, if your platelets are okay, but the coagulation factors are bad, then you'll stop the bleed quickly, and then it will all go away because the coagulation factors never came in to finish the job. So you get a late and very massive bleed. Okay? Does this make sense? Yes? Or are you guys too tired to think at this point? All right, so I will reinforce this again. All right, so drip, drip, drip. Think of platelets. Okay? Small bleeds, petechiae, 1-2 millimeter, purpura, half a centimeter, and ecchymosis, maybe a centimeter. So you get several. And by the way, this is the palate, in case you didn't recognize it. And this is the uvula here. So this is blunt trauma to the soft palate in a patient who has a platelet problem. This is what it could look like. Okay? Small bleeds. Because the clotting factors are fine. It's the platelets that didn't get there on time or didn't do a very good job of blocking the hole. Here's another example. Small bleeds. Petechia and ecchymosis and purpura, okay? But if that dough, the fibrin that binds the platelets together and keeps them in place for a long time, doesn't work, then you have a large bleed. Initially, you might have stopped it just barely, if it's a small trauma. But if it's a big trauma, even good platelets can't do very much. So with clotting factor deficiencies, you get large bleeds, and they can be, hematomas are very characteristic. So a hematoma is a large bleed into a space, or dissecting the tissue, forming a mass. So you have just basically this huge amount of blood pooled in some kind of a space, and they also often have problems with bleeding into joints, okay? So clotting factor deficiencies come with large bleeds, platelet deficiencies, whether it's fewer platelets than normal or platelets that don't work very well, you get small bleeds, okay? All right, I think I've beaten that horse to death. Now, when it comes to trying to use laboratory diagnosis for bleeding problems, not unusual for this to be featured on an exam where you kind of sort of need to know if the values are abnormal in terms of platelet counts or bleeding time. That points to problems with platelets and maybe vasculature, okay? So if someone suspects, the opposite is true too. Someone suspecting platelet or vasculature problem, these are the tests to start with. You do platelet counts and you do bleeding time. On the other hand, if it's suspected that the patient has a clotting factor problem, there are other tests that are much more valuable, called prothrombin time, partial thromboplastin time, so PT, PTT, and specific factor assays, because typically it's one of these clotting factors is just not being made enough. Von Willebrand factor, very low. Factor 7, factor 8, factor 9, all of those can be measured independently, okay? So PT, PTT, and specific factor, right? If clotting factor deficiency is suspected. Yes? Partial thromboplastin time. Okay, any other questions? All right, so those are the simplest ways for me to help you remember this stuff, is to give you just these boilerplate algorithms. This is, I already told you about this, what petechiae, purpura, ecchymosis, hematoma is, and hemarthrosis is the term for bleeding into joints. And what happens is, the reason it's called arthrosis is because with chronic bleeding into the joints, there's some inflammation, there's fibrosis, and this fibrosis is the reason for calling it arthrosis, because the joint then, the surfaces kind of start to adhere to each other and there's limited mobility. So no longer are the bones and other structures in the joint completely separate from each other. They're now kind of fusing together with fibrous tissue and bone. And that's why it's called hemarthrosis. Okay, very serious problem for these people. And it comes with certain clotting factor deficiencies, which we'll talk about in a bit. I thought that this might come very handy so that you kind of get a sense of what happens with bleeding, all right? So there's a certain timeline that a bruise goes through. If there's a single injury to a tissue, you can actually determine the age of the bruise based on its color. And the reason I even include this here is because sometimes when you see patients in the dental office, sometimes it's an injury that's inadvertent, but sometimes it's an injury that's due to abuse. And as dental providers, dental care providers, we sometimes have to be very mindful of that, and in fact are supposed to report anything that we suspect as abuse, especially when it comes to children and elderly. And on the other hand, it's also a good thing to know, because then you can sort of tell whether the patient has a single episode or has repeat over time chronic episodes of bleeding, because the bruises look like they are all from different time periods, right? They all have different colors. So it's very, very useful to have this on hand so you can actually tell how old the bruises are and whether you need to start thinking about a bleeding problem in the patient, okay? So just look at this, and it's actually very, very self-explanatory. All right, so what kinds of bleeding problems do we have? I'll just take 10 more minutes, and I promise you guys can go before 5. I promise. We'll finish on Wednesday, next Wednesday. But we'll do a few more minutes of this. So when it comes to bleeding problems, I already told you that vascular problems can manifest as bleeding problems because there's a deficiency in the wall of the blood vessel. And also, we're going to start initially, we'll talk about platelet problems. So here are just some examples. So let's say you have a patient with a vascular problem, and this kind of problem is something that as dentists we need to be very familiar with, because it's a hereditary problem, and it's a malformation of the vasculature. And the vasculature is such that the vessels are tortuous, they're weak, they're not supported by very strong fibrous tissue, And the manifestations can look very much like petechiae or ecchymosis, but they're much more well-defined, and they're actually raised papules instead of being just macules, petechiae, purpura, and ecchymosis. So if you compare these images, you can actually see that vascular problems can look a little bit or a lot like petechiae and ecchymosis, like platelet problems, but do have some distinct characteristics, because oftentimes the blood is actually still intravascular, and so it will stay red or dark red rather than go through different color changes the way it does when the blood extravasates. Okay, so we're just going to go over some of these types of problems. When it comes to bleeding disorders, oftentimes physicians call them diathesis. And as I said, it can be either vasculature or platelet problems. And then there is a separate group, which we won't have time for today, but we'll cover later. Hemophilias, where the problem is with the coagulation factor abnormalities. So you can already see, based on, since these tend to be much more similar to each other, and coagulation factor deficiencies look very, very different, present differently, that's why they're kind of grouped separately. So disorders of vasculature and platelets go together, and hemophilias or coagulation factor abnormalities are a separate group. All right. Most of them are acquired. So when it comes to vascular disorders or petechiae or platelet disorders, these are mostly caused by external factors. So infections, drugs, vascular diseases, age, vitamin C deficiency, Cushing syndrome. This is just a laundry list of things that can do this. But focus on these top two. So you have infections, which include bacterial and viral. There are drugs. A lot of drugs cause problems with vessels, inflammatory conditions of vessels, and we'll talk about this in immunopathology. So these are your main ones, infections and drugs, okay? Now, there are a couple of hereditary causes that you should know. One of them is called Ehlers-Danlos syndrome, and it's a connective tissue disorder, and obviously the function of the vessel depends heavily on how well the supporting connective tissue works, how good it is. And because these patients have mutations in the collagen, certain collagen genes, their connective tissue isn't all that good. While they have one advantage, they're very they're hypermobile. They can practically, fold themselves twice over, but they're also they bruise easily, and that creates bleeding problems for them. The condition I just showed you, this condition here, this is actually an example of what's called hereditary hemorrhagic telangiectasia. Why do we need to know about it? Well, even though it's not very common, here's another name, Weber-Osler-Rendu syndrome. It's important for us to know it because dilated tortuous vessels are not limited to soft tissues. They're also in the brain. And in fact, the problem with these vessels in the brain are such so that when we do invasive dental procedures, we actually have to pre-medicate these patients because they are predisposed to brain abscess formation. So that's why you need to know this condition. So hereditary hemorrhagic telangiectasia, which is dilated tortuous vessels, and they always present in the skin and the oral cavity. When you see these, I've seen a number of different cases, and they all look with some variability. Some have more, some have fewer, some have more extensive lesions. But they all look very, very similar with these papules, red papules. And it's once you recognize that, if the patient doesn't remember to mention it, you should ask about it because the same kind of problem could be in the brain, and therefore you should pre-medicate this patient. Okay? So those are the only ones you need to be aware of. A couple of hereditary ones, and then most of the time it's infections or drug-induced. I have to say that even though vitamin C deficiency is rare in this country, it does occur, and it's more likely to occur in alcoholics because their diet is bad and they don't necessarily take in enough vitamin C. And in fact, we've seen cases of vitamin C deficiency, which again is a collagen problem that poorly supports the vascular wall, and so they get a lot of bleeding problems. Also manifest in the oral cavity. Right. Most of this is going to be focused on platelet disorders. And so what you need to remember is it's not just about the platelet numbers. So thrombocytopenias. I remember I showed you a case of aplastic anemia. The patient has fewer than 20,000 platelets per microliter. Normally, that's supposed to be at least 150,000, somewhere upwards of 400,000. Below 20,000, they're very susceptible to bleeding. So obviously, reduction in platelet numbers makes people bleed, okay? And it's going to be mostly petechiae, purpura, and ecchymosis. But you can also have problems even if there are normal numbers. You can have very bad platelets that don't work well. They don't stick together, they don't activate well. There's all sorts of problems that can happen. And those are called thrombocytopathies. So pathy, meaning defective platelet function. Whereas decreased numbers are penias, thrombocytopenia, okay, reduced platelet number. Okay, so both of those can lead to very similar looking manifestations, clinical manifestations, whether it's the numbers or the abnormal function. These are your numbers I already told you about. I told you the kinds of signs and symptoms you see. You always see them at sites of minor trauma, and that's skin, mucous membranes, GI tract, and these patients will not uncommonly have signs of bleeding from either the gastrointestinal tract or genitourinary tract. So there will be blood in the urine sometimes, and there will be sometimes evidence of black stool, melena, okay? All right. When it comes to numbers, these are important. So it takes a very significant reduction in numbers before bleeding actually starts. But there are certain numbers that go along with certain kinds of injuries where the bleeding is manifest. So if the bleeding is during surgery or trauma, that's abnormal. It's usually because the platelets are down between 20 and 50,000. Spontaneous bleeds start at below 20,000, and finally there is a very high risk of intracranial bleeds when the numbers drop below 10,000. Okay, so remember these numbers, these are important. Now, the vast majority of these have to do with something that happened with the patient. It's not a congenital problem, so it's acquired problem. And drugs are an extremely common cause of these problems. Alcohol is one, thiazides is another, and cytotoxic drugs is another one. Infections, of which measles and HIV tend to be referred to fairly frequently. EBV, infectious mono, also comes with increased bleeding. We talked about B12 and folate deficiency, and remember that differentiation of all cell types is a problem, including platelets, and pancytopenias, including thrombocytopenias, are actually a common problem among these patients, but it takes a significant deficiency before that manifests clearly. Of course, I already gave you the example of aplastic anemia. Anything that's affecting bone marrow in general, including the stem cell population, is always going to come with increased bleeding. That goes without saying. It's obvious that if the bone marrow is affected in general, platelets are going to be affected, therefore you're going to have a problem with bleeding. It's very straightforward, it's very simple. So anything affecting bone marrow that leads to reduction in cell numbers, you're going to have a bleeding problem. Very clear cut. And we'll see examples of leukemias next time where this is very, very obvious. Okay? Oh, I already have a couple examples right here. So here's an example of a less severe a patient with chronic leukemia that hasn't advanced very far, so the evidence of bleeding is relatively minor. So besides having problem with the white blood cell population, they're not making enough platelets. It's thrombocytopenia, therefore they have petechial purpura ecchymosis. That's a straight line right there, very simple. Here's a patient with myelogenous leukemia. Here's another patient with myelogenous leukemia. In both cases, you can see here there's actually spontaneous bleeding, very, very obvious spontaneous bleeding, which tells you that the platelets are how low? Below 10,000. Spontaneous bleeding, well, 20,000, okay, you're right. 20,000, good. But here's a patient who has bleeding into the gingiva as well, even though it's not liquid blood out with saliva. Again, same manifestation of low platelet numbers, below 20,000, okay? All right, I promised to let you go at 10 till, and it's 10 till. All right, we'll continue on Wednesday. We'll talk about white blood cell disorders, and we'll finish up on bleeding, okay? Any questions, please be sure to email me.
Thanksgiving break.
Yeah, you too. Are you going anywhere? You're going home or not? Are you going to go? You're from Atlanta?
I am, but I'm not home in London.
In London?
Yeah.
You don't get to go to London?
I'll go there like during Christmas break, winter break.
Okay.
So,
Yeah, you have what, 2 weeks or 3 weeks?
well, including this week, 3 weeks basically. After this week is like 2 weeks. So 2 weeks of school and then we'll fly out.
Yeah. So what do you do when you go home?
Oh, I just go like see like my mom and stuff. And, like things about me. I go there and then with her I just travel around. Me, her, and then like my brother, sister.
How did you end up here?
I don't know. That's like very. So I came here. My uncle lives here. So came here for like school and then kind of got stuck here.
That's tough.
Now
So,
I'm like,
so you went to college here, right?
yeah, I went to EGA.
Oh, okay.
And then from there, then I started working for a little while. And it's like, well,
What did you do?
I worked for the government. I did like intelligence stuff.
Wow, that's interesting.
Yeah. And then I was like, well, let me go do something else. And then I did dentistry. I came here.
So you must have had a lot of science in your background.
Yeah. Well, I did biochem in EGA.
Okay.
So then I worked for 3 years when I graduated. I always wanted to do something like in healthcare, but didn't really know what. And I was like, well, this is short, 4 years.
4 years and you're done.
Pick up.
Yeah.